As we look at the anatomy of the thoracic spine, I just really want to draw your attention to the naming of the regions. And this is important when we talk about different interventions. We might talk about, for example, thrust manipulation to the mid-thoracic spine or to the upper. So it's just helpful to understand where those regions relate to. So that's the first thing on the slide here. Keeping in mind that you've got 12 vertebrae, 24 ribs, 12 pairs, and obviously the sternum, which can be further divided into 3 parts. What I don't want you to do here is memorize all these numbers. This was not meant to be something that you had to be able to recite, as much as to give you a real indication of how many different moving parts there are going on when you consider the articulation between the vertebrae and the ribs, and the ribs in the costochondral area. So as you can see, there's a lot going on. Many of these interactions with these joints are synovial in nature. You do have the fibrocartilaginous at the intervertebral articulations, and then you've got the synchondrosis, which is down between ribs 1, 6, and 7 at the sternocostal articulations, and that's where you have hyaline cartilage as the intermediary between the two surfaces. Lots of different muscles involved in and around and attached to the thoracic spine, and thinking about those muscles which are involved with movement of the spine itself or the upper extremity. So just some examples here. You will probably give me many more. The other thing here is we're looking at muscles involved in respiration. And I apologize, the original slides that went to print, these were incorrect. So if you look at this here, with inspiration, the primary muscle is the diaphragm, the downward movement of the diaphragm through the central tendon. You've also got the levator costorium and the external intercostals, some of the key muscles and the primary muscles for inspiration. What we know about expiration is it is primarily a passive activity. However, when somebody needs to provide forced expiration, the key muscles involved are the abdominals, the obliques, and transverse abdominis, and to a point some of rectus abdominis. So again, just be aware that I did make a correction here on this slide, and you can just kind of correct out on your handout that you have. Again, I'm not going to expect knowledge of the exact arterial or venous supply. I just want you to be mindful of what supplies arterial blood, how blood is then taken away in the venous system. And probably what's more important on this slide here is thinking a little bit about what happens with the spinal canal. It does narrow about T3, T4 in and around that area. You do have innervation from the sinovertebral nerve. We talked about that nerve before in the lumbar spine, particularly in functional anatomy when we talked about that. And then an important thing to think about is the sympathetic trunk. You've got 12 ganglia kind of lined up along either side of the thoracic spine. And some of these, when aggravated or when irritable, you can get a very distinct sympathetic reaction. There is a condition called T4 syndrome, and it's typically in the region anything from T2 to T7. You can get glove-like distribution of pain into the hands. You can also get numbness, some headaches, and you can get pain with increased deep breaths. So it typically is a sort of a reflex reaction, but again, this is affecting the sympathetic nervous system with these sympathetic ganglion and trunks in and around the mid to upper thoracic spine. Just a little idea here of where movement occurs and how movement occurs. Obviously more flexion and extension. That makes sense if you think about that movement yourself. More rotation than side bend. And again, the rotation probably is most pure in the mid to lower cervical spine, thoracic spine, I apologize. Key thing to think about the ribs and the thoracic spine. Obviously the goal or the role of the rib cage is to protect the heart and lungs. Obviously the ribs need to be able to move with respiration, and you can think of the ribs in many ways as a lever, and the actual angle, kind of that turning point of the rib, is the fulcrum of that lever. if you look at upper ribs 1 through 6, and you look at the upper diagram and you see that little idea of the pump handle, that's how the upper ribs function or move with inspiration. So it kind of lifts it up like a pump handle straight out and in front. The lower ribs 7 through 10 to 12, you're looking at more the bucket handle, so that's more out to the side. So a little different in how they work. Again, next semester we will talk in more depth about rib function and facilitating normal rib mechanics, but the key here is to consider there are two different mechanics, the pump handle in the upper, the bucket handle in the lower. As we mentioned already, in inspiration, the diaphragm is going to move down. That's going to draw the negative interpleuritic pressure to create the passage of air into the lungs. And then expiration is primarily a passive activity. So when you think about the history taking, the time to sit down and listen to your patient, they're going to tell you what's going on. You know, very often the chief complaint will be pain, but there could also be stiffness, limited movement, so just be familiar with that. You want to think about where the symptoms are, so using a body diagram perhaps to indicate what type of symptoms are they. You know, does the patient report, you know, sharp pain? Do they report perhaps a pain with a cough? An inspiratory pain makes you think more rib type in nature. Do they have a mechanism of injury? Did they fall? Did they have trauma? Did they in the past have they fractured a rib? Because very often with a fractured rib it does heal, but it can leave a lot of scar tissue. And I've done a lot of myofascial work in and around and under the costal margins of the rib, and found that a lot of patients do get very scarred down through this area. So again, history of injury, find out a little bit more, previous fractures, that's important. As I mentioned already, do the symptoms occur when breathing? Any sort of a catch or sensation with breathing usually is indicative of a rib being involved and perhaps subluxed. Listen to your patient as to what increases symptoms, what positions or activities reduce their symptoms, because this you can work into and actually consider when you put through to an intervention program. Medications and past medical history. For me, this is really important with thoracic spine because I think about my patient potentially with osteoporosis, my patient who's been on long-term steroids, and I may choose a different intervention approach based on knowing a little bit more about their medical history. And then finally, what's that patient's goal? You know, is it pain reduction? Is it restoring range of motion, perhaps for playing golf? So have that in mind as you're putting your plan of care together. Just a couple of things to think about when we talk specifically about differential diagnosis of thoracic pain. Symptoms that occur through this region, they could be musculoskeletal, they could be visceral, and there's so many visceral organs that can potentially refer to the thoracic wall, so you want to be mindful of that. And then there could be some psychological overlay as well. Typically when we think visceral, I'm going to kind of swing back to visceral here, we think about visceral pain being more vague and dull, and it may be accompanied by nausea, vomiting, those types of symptoms. It may be related to when patient talks about, you know, after having a meal. So just be listening out for things, particularly in the history, that kind of don't tie as much with the mechanical stressor to the thoracic spine and rib cage, but rather is there something visceral or internal that's creating or referring symptoms to the thoracic wall. As I mentioned, thoracic pain may originate from about all the different viscera. Also mentioned here about sweating is another element to be aware of with the patient. Some key or documented non-muscular causes of thoracic pain, and these are primarily from your textbook, the Dutton textbook. Obviously dissecting aortic aneurysm, back and surface anatomy talked about palpation of that, and sometimes it's a case of palpation. Sometimes on a slimmer patient you can actually see the aneurysm actually pulsing. Myocardial infarction, you know, if your patient has a history of cardiac insults. They perhaps have hypertension, they may have had some cardiac surgeries, and they may be on nitroglycerine. Think about the potential for there to be patient having an MI. Intercostal neuralgia, irritation of the sensory nerve endings and the free nerve endings in between the ribs. Pleural irritation, inflammation through there, which again very often will manifest and be notable when patient is inspiration, expiration. They're going to notice their symptoms, particularly irrespective of the posture or movement of the thoracic spine. Tumor and potential, again, thoracic spine is a pretty frequent place where metastases will occur, so you want to be mindful of that. Typically, with the case of a tumor, as with these other elements, they don't change with altering mechanical loading to the thoracic spine. And then pericarditis, inflammation of the pericardium around the heart, again related, potentially aggravated with increased activity. So the key thing here, we've got to keep this in mind, and really this isn't for just only to the thoracic spine, it really refers to any of the areas that we consider that there is potentially a non-musculoskeletal cause of patient's symptoms. We're not there to diagnose, we're just there to screen, pick up those patients who are not appropriate and get them to the appropriate medical provider.